Good afternoon, everybody. This is Ronald Giffler, your FMA president, and this is our fourth Friday consecutive statewide webinar to discuss COVID-19 issues relating to the survival and success of our medical practices. It's been a very interesting week. There have been new developments. Our statewide Reopen Florida Task Force finished their report, and our governor has a plan for our eventual recovery. However, with the end of April, many of us can look at our financial data and see what a dramatic drop in patient volume there has been. So we definitely need some additional help and guidance to get us through this. Lab testing continues to be in the forefront. We'll discuss some of that. We also have a presentation on telehealth, as well as our general counsel, Jeff Scott, giving us details on the regulatory update. Our first speakers are from the law practice of McDonald Hopkins. This is a national healthcare law practice, and they have offices in Florida as well as other states. They are going to give us some regulatory and particularly legal updates, and I want them to comment specifically, if they can, on lab testing. There have been a number of issues and confusion on doctors' parts as what type of testing they can perform in their office, what types of tests are regulated, how lab tests are regulated. Elizabeth Sullivan is with the firm. She's co-chair of their national healthcare practice. She has experience providing regulatory, licensing, compliance, reimbursement, contractual, and corporate guidance to healthcare provider clients. Courtney Tito is a member of the firm and is located in West Palm Beach and practices health law. Courtney counsels and represents clients in healthcare law. And with that, I will turn the program over to the two ladies from McDonald Hopkins. Thank you.
Thank you very much, Dr. Giffler. So this is Liz. I'm going to kick it off, and I think probably everybody can see me, but just in case we have some folks joining us on audio. So what we are trying to do today, per Dr. Giffler's request, is kind of give an overview in the time that we have to talk a little bit about lab testing, particularly focused not so much on independent clinical laboratories, but more so for physicians that might be considering offering testing in their office, or bringing up a laboratory. So to start, I will say you'll probably see a little bit of a disconnect in our slides. I mean, we, as a rule, the last few weeks have not been making them particularly detailed because things have been changing week to week, sometimes day to day. And so there was actually a few additional memos from CMS, and there's been some additional information that's come out from CMS and the FDA that we are going to be talking about. So a few of those things will at least try to tell you where you can find them. As a general rule, I would say that if you are interested in learning more for purposes of having an in-office laboratory, the CMS website has been very helpful, as well as the HHS COVID response website. There's quite a bit of information specific to labs, and it's labeled pretty well, so that it's pretty easy to find. So where I'm going to start, I'm going to ask my colleague Courtney to advance the slide to our first slide. But it's just a basic overview on CLIA certification. A general overview, and again, our intention was sort of to make this helpful, hopefully for all folks that are joining, regardless of practice type. The intent of the CLIA program, the CLIA program is the overarching program for purposes of, if you'd like to have a laboratory in your office, you need to have a CLIA certificate. The CLIA program is part of CMS. In order to bill Medicare, you have to have a CLIA certificate, but if you wish to test or offer diagnostic testing for patients, you also must have a CLIA certificate. In some states, you also require a state certificate. That's not the case in Florida anymore, although it was for many, many years. So the stated intent of the CLIA certificate program is to ensure that test results are accurate and reliable. And of course, that hasn't changed, even though the delivery of care and the need for testing has really ramped up. The the need for that testing to really be accurate and help people make actionable decisions is even more so. So the idea of having tests that are accurate and reliable is probably, it's always important, but it's even more important now if people are going to be making decisions, based on status of COVID. So there are 4 types of CLIA certificates. There's a certificate of waiver, there's a certificate of provider-performed microscopy, and then there's the certificate of compliance and the certificate of accreditation. And the reason that I ran through these is because, different groups, different specialties probably are familiar with different types of CLIA certificates. The compliance and accreditation certificates are the high-level certificates. That's high complexity, moderate complexity testing. Those would be what the independent laboratories have, or labs that are running more complex testing. Certificate of waiver is something that would be more common at a point of care type testing laboratory, and provider performed microscopy is specific to, physicians or other types of providers interpreting in their offices, slides and things of that nature. So what I really want to focus on for the next few minutes is a CMS memo that actually came out yesterday. And the intention of the memo was to clarify some of the things that Dr. Giffler was referring to, which is just a lot of the confusion that's out there right now with respect to the delivery of testing. So at a really basic level, the memo reiterates the idea that you must have a CLIA certificate in order to offer testing. I know that probably sounds very basic, but I think that, in this environment with all of this testing out there and sort of, I'm sorry, I didn't know if somebody had a question. I thought I heard something, a little bit of feedback. But essentially, I think it's important to reinforce the idea that you have to have a CLIA certificate in order to provide COVID testing. And that's true regardless of the type of provider and sort of regardless of the service that you're performing. And there, I suppose there could be emergency, there could be a situation in which that wasn't the case, but for now the framework is such that you must have one. The types of testing that relate to COVID, there's sort of 3 right now. There's molecular testing that detects nucleic acid from the COVID virus, and that's really the testing that tells us, does somebody have the active virus? There's serology or antibody testing, which is what everyone is talking about right now, and that measures the antibodies. So that's not necessarily always, that can detect somebody who maybe had it or, where they are in the disease. And then there's antigen testing, and that tests antigens in the blood. And I think what's important to note here is that I think antigen testing is getting a lot of press as of late. But according to this memo and according to the other guidance on the FDA's website, the FDA has not authorized any antigen testing yet. It's quite possible that will change, that someone's working on a test that will eventually be approved, but there is no antigen testing that has been approved by the FDA yet. So to the extent that you're getting calls or offers to perform certain types of testing, that is not currently approved by the FDA. That certainly can change, and the FDA is updating their website, on a daily basis as necessary, but there's no current testing like that right now. The thing that I think I want to point out sort of before I turn it over to Courtney, and this was also in the memo from yesterday from CMS, and it was issued to the state survey directors that would be performing, sorry, there's a little bit of feedback again. The state surveyors that would be coming in and surveying a CLIA certified lab or issuing the CLIA certificate, the memo that I am talking about was issued to them to help clear up some confusion around the types of testing that's offered and the types of testing that is, what testing is sort of matches up with what CLIA certificate. And what I can do after this is we'll make sure that the link to this memo is included in our slide deck for the folks listening, because I think it's very helpful. There's sort of an illustration that I think is probably more for others than the laboratory survey directors, but it's still very helpful. So right now, what CMS is saying for purposes of testing is, for any type of testing, that are test kits, what this guidance says is that for molecular testing, it is possible that at some point there will be a test kit that has the emergency use authorization from the FDA and is issued and authorized by the FDA for point of care testing that will be able to be performed in a laboratory that is that holds a certificate of waiver from CLIA, which is the lowest complexity. As of right now, on the FDA's website that talks about emergency, what they have authorized as part of this emergency, none of the test kits that I have been able to identify on the FDA website right now are permitted at that low level of complexity, meaning certificate of waiver. We expect that they're going to come. It's just right now, each one of the tests that's listed on the FDA website is required to be run by a high complexity or a moderate complexity laboratory. And if you hold a certificate of waiver and nothing else, then presumably you are not a high complexity laboratory or a moderate complexity laboratory. Excuse me. Also importantly, serology test kits and antigen test kits, according to this memo, neither of those are going to be approved for point of care, at least at this point. So the way that CMS is categorizing this, molecular testing may be something that can be done at point of care. Antibody serology or antigen testing, that is going to have to be done in a high complexity or a moderate complexity laboratory, which means that's a laboratory that's holding a certificate of compliance or a certificate of accreditation. And what that means is that your testing personnel has a higher level of sophistication and experience. And so I think that is relevant as well. So sort of the takeaway, I would say, this is a lot of discussion around basically where we are today is that it is possible to have testing in your in-office laboratory. However, at this point, most of the testing that's available is only approved by the FDA as high complexity or moderate complexity testing. We anticipate that at some point there is going to be this point of care that will be run by labs that only have a certificate of waiver from CLIA. But at this point, that is not something that the FDA has approved. There's some very confusing designations on the FDA website that sort of say that it can be point of care and it can be waived, but only if it's held by like a high complexity laboratory, which is a little bit confusing. But I think it's one of those situations where the government is running very, very quickly, and they're sort of struggling to keep up. So with that, I will actually turn it over to Courtney and let her go through a few of the points she wants to make, which I think will dovetail nicely with some of the other presentations today. Excuse me.
Good afternoon, and I appreciate the opportunity to be here. One of the first things that I wanted to discuss today is a press release that was issued yesterday regarding some additional waivers that are coming out that we think would be, of particular interest today regarding lab tests and ordering a lab. So there was this press release that came out from CMS yesterday, and some of the highlights from that, and again, we're still digesting this as we go through it, but some of the highlights from this are that physician orders are no longer required for beneficiaries to obtain these COVID-19 tests that Liz was discussing, or other lab tests that are required for COVID-19 diagnoses, like flu tests or some of the other ones where they can use them to determine whether COVID-19 is actually the correct diagnosis. The tests will be covered when ordered by any healthcare professional that's authorized to order tests under state law. They are also allowing pharmacists to work with physicians to provide assessment or specimen collection services, and then the physician can bill Medicare for those services. And the other thing that's come out too is there's physicians can use code 99211 to bill for assessing beneficiaries and collecting lab samples for COVID-19 testing, and they will allow separate payment even when that's the only service that the patient receives in the office. And again, these are for Medicare coverage. And I think Liz covered it, but they are going to cover certain serology tests. They have not determined what that reimbursement rate is going to be. To my knowledge, I did check again not long before the presentation, and I didn't find it, but I'm sure that will come out soon. And Liz also mentioned that they will eventually start covering lab processing of certain FDA-approved tests that beneficiaries can do at-home collection. So some of the newer waivers that came out last night that I thought might be of interest. There was another memo that CMS put out in March that talks about some of the CLIA CMS enforcement. The first thing that's important to note is that the CLIA program doesn't fall under this Section 1135 waiver authority that everybody's been hearing about, where CMS is issuing a lot of the blanket waivers. So CMS can't issue blanket waivers regarding these requirements. What CMS has decided to do is exercise its enforcement discretion. So on March 26th, they issued this memo, CLIA Lab Guidance during the COVID-19 public health emergency. And they covered certain topics that are related to this. And I'm going to run through them quickly because I know we're using up a lot of our time. But there is going to be, for those of you who are interested, there is going to be expedited processing of CLIA certification so that labs can perform COVID-19 testing as quickly as possible during the public health emergency. Labs, may not be of note to everybody, but labs will also, that are within a hospital and a university hospital campus, may hold a single certificate for all the lab sites within the same physical location. So that's something else that they're offering. And then there's going to be enforcement discretion regarding the remote review of pathology slides, which means that CMS is not going to require a separate certificate for labs located at temporary testing sites, and that includes pathologists reviewing slides at home. There are certain conditions that must be met for labs to use these temporary testing sites, and those are listed in the memo, and we can certainly, go over those afterwards if there are additional questions regarding that. Proficiency testing. There's also going to be enforcement discretion regarding proficiency testing so that labs can temporarily suspend the performance of this proficiency testing under certain conditions. They cannot do it when the test is currently being performed, but if there's a suspension that's required due to shortage of staff or supplies or other reasons, then labs can certainly get that approval. There's going to be alternate specimen collection devices are going to be allowed, and it's important to note that all of these waivers and enforcement discretion is only valid during the COVID-19 public health emergency, that if you are an accredited lab, you need to follow your accrediting organization requirements, and that labs need to follow applicable state laws. And as Liz mentioned, Florida doesn't have a separate lab license, but there are other requirements for personnel, et cetera, that will be required for anybody doing lab testing. So thank you.
Thank you very much.
Thank you.
I think one thing we can take from this is what's the rule today may not be the rule tomorrow. So keep track of what's going on. Our next topic is also very, very relevant to this, but different. It's telehealth. And this is going to be presented by the Privia Health Group. Privia Health is a multi-state physician practice group containing over 2,000 physicians and other healthcare providers in multiple states. It's one of the fastest growing independent medical groups in the U.S. Privia understands doctors need to be successful both in the fee-for-service and value-based care environments. And we have two speakers from Privia to discuss healthcare and telemedicine. First is Amy Waller, Vice President of Health Information Management and Coding. Ms. Waller has over 20 years experience in healthcare coding, compliance, billing, and management. Her training includes all kinds of experience with CPT, ICD-10, HCPCS, Rick suggested, and all other areas of healthcare compliance. Also with Privia is Jeanette Wood, Vice President of Revenue Cycle Management. Ms. Wood is an experienced leader of revenue cycle management and demonstrated a history of working in the hospital and healthcare industry, skilled in medical billing, strategic planning, process improvement, and compliance. So with that, I will put the program over to Privia. Thank you both for coming to us today.
Thank you, Doctor. I appreciate being here. Can you hear me okay?
Yes.
Okay, thank you. Good afternoon, everybody. This is a perfect segue after the other ladies were speaking into what we're going to talk about today with Privia. We are going to start with our disclaimer, but we're going to move right over that. That's fine. We do have a disclaimer here. It's just really if you need legal advice, that's not us. That would be the folks that we've just heard from, but you can move forward with that. We're going to start talking first a little bit about diagnosis coding, only because we find that we have a lot of data over the past about 6 weeks, and we're noticing that sometimes the diagnosis coding isn't done as it should be, and there are some dates. So first, I just want to point out that the B9721 code for what was originally used, that ended 3/31. So you may use that code until then. But for COVID disease, you'd use the U07.1 starting April 1st. And it's really important to know too that if you have to go back and correct any claims or anything like that, on the first one you want to code the manifestation, and then you'd code the B97. So we always want to have two codes when we have a confirmed coronavirus case. The second is opposite, of course. It's going to be more confusing, but you code the manifestation after the COVID diagnosis. Two important things to remember. The other two things are we have the codes for if they are suspected, or you're not sure if the patient has it, the patient may have been exposed. We want to use those codes too. You can also use those codes with symptom codes. So make sure that you are really up on how we code for coronavirus. It's super important. The other thing I want to mention that HHS will provide reimbursement at Medicare rates, but you have to make sure you're using the right diagnoses. Everything is going to be driven off if it is a service that's related to a COVID treatment, an order for a COVID test, things like that. So we always want to be mindful if it's about COVID, we want to have a diagnosis code to do with it, whether it's a Z code or whether it's an actual confirmed case. So I always look at it like this. We have diagnosis coding, or we have diagnoses, we have documentation, then we have coding, which leads to billing. So we're going to kind of talk about a little bit like that. So first of all, telehealth services. What are telehealth services? We've been hearing about it a lot over the past 7 weeks. When we think about telehealth services, it's not like a certain amount of codes. It is today for COVID. But what telehealth services are, they're really just services that are performed using a technological, audiovisual. It could be video sometimes. It could be an online portal things. There's different ways we can look at telehealth services. For the purposes right now, there are actual sets. CMS has a list of codes that can be provided through telehealth. And the AMA, or for commercial carriers, they also have lists. We can blend these lists together, and there's an awful lot of codes that can be done telehealth. When you're coding for telehealth for E&M, let's say, it's exactly as if it were in your office. You would do the exact same types of documentation. We'll explain Medicare in a minute, but it's just like it was an in-office procedure. And the payment rate will be the same as well for those codes. So I think it's just important to know that telehealth are codes that are in the CPT book and HCPCS, but they can be done virtually. Also, I want to make sure that I mention that CMS telehealth services, they require audio-visual. If, for example, you have to speak to someone with a telephone, you'd use a telephone code. Hopefully we can get that changed. They're trying to get that changed, but it hasn't changed yet. So that's how telehealth works. And again, I just want to mention there are two sets. There's the CMS list, and then there's the CPT list of which codes are allowable. Okay. All right, so Medicare has an interim set of rules for documentation. And it's very much like what's going to change when we go to 2021, when we have our E&M documentation changes. So for right now, for Medicare and Medicare Advantage, providers can use either time or medical decision making. Now you can, if you'd like, use the 95 or 97 guidelines you always use, but for the interim, this is easier, and it's a little bit different in the time area. So currently, if you code by time, you also have to have the documentation that 50% or more of the time is spent on counseling and coordination of care. You don't have to do that with time right now for Medicare, and that's super important because that's a lot easier. You just need to document the total time. So here are the total times. As a matter of fact, CMS had their own times, and then yesterday they changed back to the CPT typical times, and here they are. So as long as you are documenting the total time of that encounter, then you may use these typical times to level your E&M services. Medical decision-making is another option, and medical decision-making, there is no difference. So you would still go over the number of possible diagnoses, the amount or complexity of data, and then combine that, of course, with the risk from the risk table. So this is also, again, I just want to point out, it's not a bad thing because it's going to exactly be what it's like in 2021. So this is kind of good practice if you want to give that a try. Again, these are interim rules. Next, I want to talk about telephone E&M services. Okay, if you can do a virtual visit or a telehealth visit like we just talked about, the regular E&M codes, there are some counseling codes, there's a large list of codes. There's some carriers even allow preventive codes, but make sure you get those correct lists. But if you have to do a telephone visit, Medicare now covers them as well. The telephone visit has rules. So, and that's because these are in the CPT book. These have been there. There's no difference. You could have been doing these all along. These aren't like COVID. The only COVID difference is that Medicare now will cover it. So when we talk about a telephone E&M service, we want to make sure that we understand there's no modifier necessary because this has always just been a technological code. You use the place of service that you normally would have reported, and it can be for new or established. If you notice in the descriptor, be careful of descriptors right now during COVID because a lot of that has been waived. You can have new patients for these telephone visits. You must document the time again. As you can see, they're time-based codes, so it's important to document how much time has been spent. A recommendation that I would say is to always, during COVID, actually anytime, document the amount of time you're spending with the patient. Again, it's a good practice for 2021. So these are the 3 telephone codes, and here's an example I want to go over quickly. So an established patient calls the office of the physician to discuss a new problem, a new illness. The physician gets a brief history, makes treatment recommendations, all of which are documented. The patient is instructed and advised to call if symptoms are increasing. The call lasts 15 minutes. So they're not bringing the patient back in the office. This is a telephone visit. This is okay. Also, if you have a patient that is, it could be a patient, it could be a patient's parent, it can be also a guardian. So I just want to, that is kind of how the telephone works. Again, CMS does cover this, or Medicare does, and just yesterday, there was an announcement that they increased the rates of the telephone visits from, they were originally about $14 to $41, but now they're going to be about $46 to $110. So, probably the 99441 will be 46, et cetera. So they have raised them. Is it as much as doing an E&M? No. That's why we always say, if you can, if it's appropriate, if it's possible, do a telehealth visit. Medicare virtual check-ins. So Medicare does have these short check-ins, and it's just about 5 to 10 minutes. It's a conversation with your provider about anything related to a problem that you may have. They're very short. Oftentimes, it'll just be to decide if the patient needs to come in for a virtual visit for something more specific, like an E&M visit or a counseling visit or something like that. There are rules here, of course. This is also a HCPCS code. I think there's one commercial payer that covers this code. Jeanette does that part, so she'll be able to explain that. But this also has to be done, again, real-time audio, telephone, or audio visual. It doesn't have to be HIPAA compliant technology, but of course we always recommend that you have that and document that. It can be new or established patients again. So even though the descriptor says that it has to be established, they may be new. That's super important. There are certain providers that can do these. This, again, can only be a physician or a qualified healthcare professional. We want to make sure that we really understand that a qualified healthcare professional does not include nurses or MAs. No geographic restrictions, which has been very helpful lifting that. I hope CMS keeps that lifted permanently. So again, I think I already mentioned this. The example would just be that a patient calls with symptoms and they're going to decide if the patient needs to come in for a virtual visit or not. So this can be built, you can build this, and again, it's not that much. I think it's about $12, maybe a little bit more for the G2010 code. Then we have Medicare EveIslets. EveIslets are a little bit harder to document, so you kind of have to figure out how you're going to have your workflows set up. So these are, face-to-face. They are patient-initiated, and they are they can be done through over a 7-day period. This is where time really has to be documented very well. And there's 2 sets of these Medicare EveIslets. There are the ones for physicians, which you can see here, the 99421 to 4423. They are for physicians and qualified healthcare providers. And they also are for other clinicians they have added. They keep adding them. Right now, I think there's physical therapists, occupational therapists, speech language pathologists, but the list grows. So definitely check with your payers which providers can perform these codes. The other codes down here are used for clinicians that can't bill E&M, and that's pretty much a good way to look at that. Time is super important. So how you calculate time for these codes, it's a cumulative time, and it includes the review of the initial inquiry. It includes the review of patient records that are pertinent to the assessment of the patient's problem, personal interaction with clinical staff focused on the patient's problem, development of management plans, and subsequent communication with the patient. So that you can roll a whole lot into that. So that's why it's important to really understand how do we do time with these Medicare EveIslets. So we can provide you with more details about that if we like. So again, these can be online, telephone, email, or any other digitally supported communication. So that's what I have, and now Jeanette will follow up adding the billing piece to the coding piece. Thanks, Jeanette.
Thank you, Amy. Good afternoon, everyone. I want to start off by stating that it is extremely important that when billing, that we make sure that you have the correct place of service and modifiers on your claims. The payers are constantly updating how they want the claims to be billed. And by billing correctly, this will ensure that you are getting parity, meaning you're getting the same rate that you would get if you saw the patient face-to-face. You'll also have less denials, and it will allow for the correct waiver of cost sharing for the patient. So the insurance carriers that are waiving for COVID-related and non-related diagnoses will adjudicate the claim with the patient not having any liability. Each of the payers have made up how they want to make the claim to be submitted. Medicare wants a place of service of 11 with a modifier 95. Medicare wants a place of service of 02 with a GT modifier. Some of the commercials want 02 as a place of service or 11. So it's very important that you look at your payer websites and understand how they want the claim to be submitted. It is also important to know that the services that each payer will reimburse during the pandemic. As Amy mentioned, CMS has a complete list of CPT codes, but we are finding that commercial payers are adding additional services. For example, some of the payers are covering the preventive visits. What we found that it was very difficult for our offices and even the billing department to understand all the differences by the payers. So what we created was a workbook called the Market and Payer-Based Coding and Billing Workbook. And what we did is we took every payer for each of our markets and created a grid on all the CPT codes that they will cover, any special documentation guidelines they want for that CPT code, and any special modifiers that they want. And what we have pictured here is an example or pictures of the spreadsheet that we have. We started with the table of contents because we are in different markets, and you can click on the link under the table of contents, and it'll take you right to that section on the spreadsheet, so providers and or staff do not have to scroll through to get to the CPT code that they're looking for. We provide immediate access to this. We have shared this on our Google Drive, and we have staff that are monitoring the payers daily and making immediate changes to our spreadsheet. And because it's a shared Google Drive document, our practices and staff get real-time updates on all of the changes. We also note any specific payer coding and billing guidelines on the workbook, and we create links to those documentation guidelines. Anything that's in blue on our spreadsheet, staff and providers know that this will take them to the documentation guidelines or any specific payer guidelines for those CPT codes. Some other important things to consider. We have to ensure that we are receiving parity reimbursement. In the beginning, Medicare said to bill under place of service of 02 and was reimbursing under the facility rates instead of the non-facility rates. And because payers are constantly changing the way that they want you to bill, it's very important to monitor your allowables. We are very fortunate to have a system where we can load all of our contracts and allowables and can determine easily when we do not receive the correct payment for our claims. We also created a tracker on all of our claims that were paid incorrectly or denied or were adjusted to the patient fully. And we, in the Revenue Cycle Department, use this to monitor any trends we're seeing with the payers, or if we need to alert of a particular issue with a payer to our primary care offices or any of our offices so that we can ensure that they are abreast of any changes and or trends that we are seeing. We also use this tracker to escalate issues. We use it to create local rules on our billing system so that if we know that a payer is expecting a certain modifier for a particular code, or if they want to place a service that's different than what we're used to, we can create rules in our system to hold those claims so that we can fix those before they go out the door. And we also created a tracker to monitor any of our denial amounts and claims that we've resubmitted to ensure that we are recouping the correct amount, and we are monitoring that on a daily basis. So it is very important to monitor your claims to ensure that you are getting paid the correct amount. And if you submitted claims based on early March decisions by payers, especially like Medicare, they want to place a service of 02, you need to rebill those claims to get full parity rates for your physicians. All right, and I guess that's the end of our presentation. We do have a few things. Did you want to go over these, or are they just for appendix purposes? All right. Thank you, everyone.
Thank you very much. Thank you. Our next speaker needs little introduction. He's our General Counsel, Jeff Scott, and he handles all our legal affairs and will give us an update on events in the past week since last Friday, including our Reopen Florida plan. Jeff?
Okay, so I'm going to talk to you about Executive Order 20-112. I don't know how much you got into it, Dr. Giffler. I'm sure everybody's aware of it based on the governor's press conference on Wednesday. The order came out shortly thereafter. It does a lot of things, but what I want to focus on are the impact on physician practices. A couple things to be aware of about the order. The Safer at Home portion of the order that was set to expire on April 30th has been extended to May 4th. The prohibition on elective procedures, that was Executive Order 20-112, 2022 that was set to expire on May 8th has been lifted effective May 4th. So, beginning on Monday, May 4th, all physicians in the state of Florida can resume doing elective procedures. And I know that Miami-Dade, Broward, and Palm Beach are still subject to the safer at home restrictions for the time being. But physician practices are essential. They were never shut down. They can continue to operate in those 3 counties. And the portion of Order 20-112 lifts the prohibition on elective procedures for these 3 counties, as well as the rest of the state. So all physicians in the state of Florida on May 4th will be able to resume practice as they did prior to the imposition of Executive Order 20-72. That includes cosmetic procedures, Botox, injectables, anything a physician's office was doing prior to the order being instituted, they can continue or resume doing on May 4th. There are 4 conditions, though, that have been opposed on reopening. A couple of those really don't apply to physician practices, and you really don't need to pay attention to those. The first condition is that a facility has to have the capacity to immediately convert additional beds for COVID-19 patients in a surge capacity situation. That is a hospital-directed condition. It does not apply to physician practices. Obviously, they don't have hospital beds that they can supply, so it's not something that you're going to have to comply with. The 4th provision is that a facility does not refuse to cooperate and support skilled nursing facilities, assisted living facilities, and other long-term care residential providers. Again, that is a hospital-based directive. Most physicians don't have an agreement or a support arrangement with a nursing facility, and so it's not going to apply to them. I contacted the governor's office and spoke to the governor's general counsel about this, and he confirmed that the A and D provisions really do not apply to physicians' offices, and it is a hospital-based directive. The one that physicians' offices are going to need to comply with, though, is the requirement that to be able to resume elective procedures, you have to have your own personal protective equipment. And you cannot rely on state or federal resources or assistance to procure that PPE. You have to use your commercial, supply sources to get the PPE you need to be able to practice and resume elective procedures safely. So that's something to keep in mind as you go forward. So basically, that's Executive Order 20-112. Of course, if you have any questions, if any physician or FMA member has particular questions about how to comply with this order or any of their rights or obligations going forward, feel free to contact me anytime. My email is legal@flmedical.org, and we'll be happy to answer any questions you have. So, Dr. Giffler, that's all I have.
Thank you very much. If anyone has any questions, I noticed there have been none submitted so far in the chat box space. So I assume we've told you everything you want or need to know.
Yes, sir. We actually do have some questions that have come through. We do. I can ask some of those if you'd like me to. The first one was for Ms. Sullivan. If Florida issues a public health exception so that physicians can test with POC tests in their office while caring for COVID-19 patients, is there a concern by the state that restricting testing is putting patients and staff at risk?
So the question, if I heard the question correctly, Matt, the question is whether or not it's possible for physician offices to offer testing if it is approved at a state level, even though the physician's office CLIA certificate status may not be consistent with what the federal government is requiring?
Yes.
Did I understand that correctly?
Yes.
That is an excellent question. I can't say that I can speak as a state law expert, or sort of, I guess, constitutional law between the state and the federal. But I would say that to have a CLIA certificate, I mean, for purposes of being reimbursed by a government program, you have to have the CLIA certificate. So from my perspective, I would say that that would need to be taken into consideration. Private payers often follow or are consistent with whatever Medicare requires. But I would say that if the state works something out with the federal government, then that should be clearly laid out, and that would be acceptable. I'm not aware of that, but I don't know. Certainly, Jeff, I don't want to put you on the spot, but I don't know if you're aware of anything like that in the state currently.
Yeah, that was the question. I know where this question came from. It's an issue that we've been working on, and it's basically there's some antibody tests that physicians have that they would like to be able to do in their office without having to get a CLIA certificate. Apparently, they're simple tests. They're simply they're like pregnancy tests. There's no need for them to be submitted to an independent laboratory. And so there's physicians that would like to be able to offer these. They don't have a certificate, and there's a question of whether you can get a public health exception, whether the state can issue that and allow physicians to do it in their office, irregardless of the federal requirements. And that's something that we've wrote a letter to the governor requesting assistance, and it's an issue that's still pending out there that we don't have resolved.
Got it. Well, it's interesting you say that. The one thing I will say about that is Courtney touched on this, and one of the things we actually ran into is at a state level, as far as the waivers, the emergency waivers, the 1135 waivers that states are requesting to do certain things, the CLIA certification framework is actually outside of that. So the power and the authority that CMS has with respect to the 1135 actually doesn't, the sort of the framework for purposes of the CLIA certification is in another, it's a separate bucket, it's a separate framework. So I wouldn't be surprised if there is a way to get there, just as you guys are pursuing. But, I would say as things currently stand, I don't necessarily see that there is some other workaround automatically available, if that makes sense. I wish I had a more helpful answer.
Okay. Our next question is going to be for our folks at Privia. What code should we use for asymptomatic patients that wish to get COVID-19 testing with or without a potential exposure to a suspected case?
That's a really good question, because I see that come up a lot. And the problem is, there's not really medical necessity to do that. They just want to know. I just saw that happen yesterday. So if the patient thinks they may have been exposed or thinks maybe they had a fever in February, the only code that you could probably use would be a Z code around that they might think they may have had it. Currently, there's not really a code with medical necessity to just say, I want to have that antibody test. So I think that they'll probably come out with something. That's really all I can tell you. There's a feared medical condition code. I don't know if that would pay, though. So that's a good question. There's not medical necessity to just do a test just because the patient wants it. I understand it's a sensitive issue, but that's something that I'll look into, and I look for it almost every day, but I'll look for some guidance on that.
Okay, and here's another question for you all. When you mentioned for Medicare waiver of patient cost share, does that mean they will pay the provider for coinsurance, or are they asking the provider to waive coinsurance?
So for COVID diagnoses and COVID patients, Medicare, as long as you build a CS modifier with your claim, Medicare will waive the coinsurance for the patient. So they'll pay you at 100%.
Okay, I'll let anybody decide who wants to take this one. Other than typical screening, is any pre-op testing recommended for COVID for elective surgeries? Jeff, you have an answer for that one?
Sounds like a medical question to me, not a legal question. So Dr. Gifler may be able to answer that one better than anyone.
The hospitals are requiring a PCR negative test within 24 to 48 hours in order to have the patient receive elective procedures. Is that what the question was about?
Yes, that was part of the question also.
Now, that's on a institution by institution policy, but I believe most of them are adopting that, and our physicians' offices are also interested in some means to test patients prior to receiving procedures in the office. And as mentioned previously, access to testing in that timely manner is going to be an issue for a number of the offices.
And here's another one for Jeff. Can we require patients to wear a mask when they come in the office? Do we need to provide the masks? Can we refuse a patient without a mask?
Yes, yes, yes.
Very easy. Okay, and then this one maybe.
Yes, man.
This one says that it's for Jeff, but Jared may want to chime in on this one. Any updates as when the HHS may disperse Medicaid relief funds in Florida?
Jared?
Yeah, I think this one's going to be me. So a couple of things. So HHS had an initial $30 billion tranche of money, which I think everybody knows went out based on your 2019 Medicare fee-for-service revenue. And it came out to roughly 6.2% of that. There's an additional $20 billion that was that they have begun dispersing that is supposed to be based on revenue other than Medicare fee-for-service revenue. And this would benefit practices that take Medicaid, commercial, et cetera. However, based on the current guidance on HHS's website as of today, they do clarify that the people who would be eligible for this second tranche of money had to have A, billed Medicare in 2019, and B, previously received a disbursement of money. In other words, the people receiving the second tranche of money will also be those people who received the previous tranche of money based on the information as it currently stands. And so while that would include individuals who, are in the Medicaid space and, do more MA and commercial, and there's a formula that you can use if you want to get an idea of what your the total value of your payments under these programs should be, so that you have an idea of how it will affect you individually. And if you give me just a moment, I can give you that formula, which is individual provider 2018 revenue divided by 2.5 trillion, which is obviously a big number. And then you take that number and you multiply it by 50 billion, another really big number, and that will be your expected general distribution. Again, so the formula to get an idea of how much you should get out of that total 50 billion should be individual provider 2018 revenue divided by 2.5 trillion times 50 billion is the total expected general distribution, assuming you're eligible. Another thing about this whole eligibility piece is that I would really, for anybody that's trying to figure this out and they're confused, I would go straight to the HHS website, read the FAQ there, which goes into this in a little bit more detail. And keep in mind that, HHS has released several updates to their guidance in the past on any number of things, clarifying different aspects of the program formula. So just make sure that you check their official website so that you have the latest official information, and that you are, keeping in mind that additional information may be made available at any point in time regarding, other targeted distributions that may be separate from the distributions I mentioned, or other types of funding for which you may be eligible for that may be pertinent to your practice, including the, the payments for uninsured COVID-19 patients and related treatment that I believe was already referenced on this call. So I just want to make sure to qualify that this is by no means an attempt to provide a comprehensive answer to that question, as the disbursements coming from HHS are ongoing, and that there is still additional money that has not been spent or dispersed or allocated generally. But do keep in mind that that additional $20 billion distribution may affect many providers who serve Medicaid patients. It is not a Medicaid-related payment per se. But many of you may nevertheless benefit from that who see Medicaid patients. And again, you can check the HHS Provider Relief site for the latest information. We also have an article that has been updated with links to the FAQ explaining that, and to the article in whole. And I'm going to be, again, just to clarify, I'm providing a brief overview of this, not attempting to, spend 10 minutes giving a full didactic. So I'll go ahead and stop right there. And if we get more questions, I can take them as they come.
All right, thank you, Jared. And we only have a couple more minutes here. We have a lot of questions, so I want to remind everybody, if your question does not get answered, please email us at membership@flmedical.org. That's membership@flmedical.org. The next question here is for Ms. Wood. Should a CS modifier only be used when taking care of a COVID patient?
Yes, for Medicare, yes. The CS modifier is only if it's a confirmed diagnosed COVID patient and or if you're doing the testing for that patient.
Okay, and then one more question for you. Using 99211 code for ordering COVID testing, is it for commercial lab or can you apply to Department of Health testing as well?
Oh, that's a good question. And I do not have that answer, but I will get that for you. And unless Amy, you know.
Yeah, I think that was mentioned by the previous speakers, but the AMA has allowed 99211 if they're going in to have the test, that they can also bill a 99211. For ordering it though, haven't seen that, but I haven't seen that come through. Usually physicians don't use that code anyway. That would be a nurse code, and nurses aren't ordering this, so I'm not sure about that. I'm not sure that's something I have not seen. So we don't right now recommend using that for a nurse, for a physician to order the test. They would have an E&M code or something else, evaluate the patient.
And then the last questions here we're getting quite a bit about if any of Jeff's presentation will be in writing or other guidelines put out by the FMA. And yes, we will be putting things out in the next week on reopening and on the guidelines for the executive orders. And with that, it is Dr. Giffler, did you want to say a few words to close us out?
I just wanted to thank all our speakers, and I am sure there'll be new information this time next week. Testing is still a moving target, as well as a number of these federal programs. We will update you on the latest tranche of money, as well as a new program for compensating for uninsured patient care. And so stay tuned. We're here to help as best we can for all of us together. Thank you.
Thank you.
Thank you.
And it was said, if you have a question left over, email us at membership@flmedical.org. Thank you for all presenters today.
Thank you.
Thank you.
Thank you.
Thanks very much. Take care.